Hi, good evening. I am Mike Perlante, and on behalf of Dynaflex, we welcome you to tonight's webinar. The title of tonight's webinar is Achieving Clinical Efficiency and Profitability with Dr. Tito Norris. Dr. Norris is someone that I've known and worked with now for more than a few years. He operates one of the busier practices in the San Antonio area. And what's amazing is the amount of volume that he does, the amount of tough clinical cases that he is involved in, the amount of challenging interdisciplinary cases he routinely is involved in with specialists in his area, and doing all of this with having one of the most impressive work-life balances that we have seen. He's able to achieve all of that by being a systems ninja and also really developing out-of-the-box methods for diagnosing and treating tough cases. He is a clinical master, he is a business master, and he is the developer of the Norris 2026 system. And he's a really good person. So we are excited to have him join us and join you tonight. Throughout the presentation, if you have any questions at all, please type them into the chat box. Dr. Norris and I will jump back in towards the end and address those questions and answer them, as well as talk through anything that needs to be. Two quick things. This is one CE, so you will receive that CE via email within a week. Once in a while, it will wind up in your spam box, so just look there to make sure it didn't wind up there before thinking that we didn't send it. Secondly, as an added bonus, attendees are going to receive a really cool special offer following this, so be on the lookout for that. With that being said, let's begin tonight's webinar, Achieving Clinical Efficiency and Profitability with Dr. Tito Norris.
Hi, I'm Dr. Tito Norris. I want to thank you so much for spending your time with me over the next hour and a half as we talk about the features and benefits of the Norris 2026 system. Just as a friendly reminder, if you have a question, go ahead and just put it in the chat box and we'll answer those questions at the end of the webinar. We're going to be talking about the birth of the 2026 concept and where this idea came from. Hopefully, during this period, we'll be able to kind of maybe open up your mind a little bit, change the mindset, and see some things that maybe you thought were impossible before, and perhaps open up some possibilities. We're going to look at the efficiency and the value proposition of the Norris 2026 system. And we're going to go over some Class 1, Class 2, and Class 3 cases that were treated with the system. Finally, we're going to wrap up by applying the core diagnostic process to the treatment of 3 interdisciplinary cases. Let's go ahead and launch it. So this idea about a 2026 bracket slot system actually hit me a long time ago. And I'm going to start it off with a little story here. So a little girl and her mom were making a roast. And as the mom was preparing the roast to put into the oven, she cut off the ends of the roast. And the little girl asked her, "Mom, why did you just do that?" She says, "Well, honey, gosh, I don't know. It's the way that my mom taught me how to do it. And so that's just the way I've always done it." And she said, "Yeah, but why? Well, why did you do that way?" She said, I honestly don't know. We'd have to ask my mom." So they called up her mom and they said, "Grandma, why is it that you always cut the ends off of the roast before you put it into the oven?" And she said, "Well, gosh, I really don't know. It's just the way that my mom taught me how to do it, and it's always come out really good, so I've just kept doing it." So they called her mom and they asked her the same question. They said, "Great grandma, why is it that you always cut the ends off of the roasts before you put it into the oven?" And she said, "Well, actually, dear, it's because my pan was only this big, but my roast was that big. So I had to cut the ends off of the roast to make it fit into the pan." And so as you can see, no one ever really questioned this tradition. It's just a tradition that was passed down from generation to generation, and everyone just sort of assumed that the process was gospel, was that's just the way you did it. No one ever really questioned it. Well, the same is really true in orthodontics. When 150 years ago, this man, Edward H. Engel, was using an 022 bracket slot system to straighten teeth. And he was doing that because that was about the right size that he felt that he needed in order to use the wires that he had at his disposal in the 1800s. But, you know, we're not using this kind of bracket system anymore. You know, we no longer have to spin our gold wires down, and we're not working with such malleable metals. We've got much more, you know, modern and high-end materials these days. And so, you know, the 022 bracket slot system really is great-grandmother's roasting pan. So we've used it and continue to use it because that's just what the previous generation did. And there really hasn't been any other significant choice in our armamentarium for the last 150 years. So around 1989, and that's about when I got involved with orthodontics, I kind of had the audacity to ask the question. And the question is, to the orthodontist whose office I was working in, listen, I understand that the bracket system here is an 022 slot bracket system. So why is it that the strongest wire that we have in the entire office is a 19 by 25 wire? And the orthodontist answered, well, honestly, a 21 by 25 wire, which is the wire that would fill the slot, it's just too heavy. I mean, it would break brackets, it would burn roots, it would cause the patient pain. And so it's just not the best wire for us to use in orthodontics. And so I said, well, you know, honestly, coming from an engineering perspective, I mean, I was an engineering student, and I said, well, why don't we just use a bracket that fits the wires that we like to use? And the orthodontist said, well, that'd be nice, but it just doesn't exist. There's nothing like that out there on the market, and this is all we have to work with. So we just kind of make do. And so it really is like the baking pan. It's you know, it's just been this way because of tradition. And so, you know, why is it that 80% of the world uses this 022 slot bracket size, and yet less than 1% of the wires sold in the world is 21 by 25? Well, it's for the reasons I just delineated. Those 21 by 25 wires is just simply too heavy. It's like rebar. It breaks brackets, it burns roots, it causes patients pain. And so, you know, the analogy I like to use is if you were fixing a fence, okay, and you had this 19 millimeter nut that you needed to go tighten, okay, would you go and you look in your toolbox and find a 22 millimeter wrench? Well, of course not. You wouldn't do that. You'd go look for the wrench that fits that 19 millimeter nut. And the same is true if we like to use a 19 thousandths of an inch wire. Why shouldn't we just go ahead and get a wrench, i.e. a bracket, that fits that wire? I've got to give a lot of credit to these gentlemen because I think they've done a lot for our profession, and specifically for in the arena of passive self-ligation. Both Dwight Damon and Tom Pitts are brilliant guys, and really I think a lot of us have stood on their shoulders and learned a lot from them. And kudos to them for really kind of taking the arrow and being pioneers in the passive self-ligating world. And I think that you know, as we move forward, I think that there's some of us that need to sort of just take up the torch and bring that concept, that passive self-ligating concept, to the next level. And so you have to ask the question, well, why passive self-ligation? You know, what's the big deal with PSL? Well, these are my clinical chair side assistants, and I have to tell you that, you know, one is left-handed, one is right-handed. One uses a medium amount of force when she ligates a steel tie around a tooth. One uses kind of a loosely tied. One ties it very tight. This one tucks the pigtail to the mesial, and this one tucks it to the distal. So what that means is that there's a tremendous amount of variability that happens whenever you're steel tying wire into the bracket. And I'm all about systems. I love the fact that in a passive self-ligation system, you've essentially got two choices. The bracket's either open or it's closed. And so there's no variability among your clinicians or your clinical assistants. And so that, to me, describes a system. And so the bracket is either open or it's closed. There's nothing in between. And I love consistency. I love predictability in my practice. So we know that no matter how tight of a wire we get in there, there's going to be a little bit of slop or play in each direction for every thousandth of an inch of tolerance that we have between the wire and the bracket. And so, you know, for an 022 slot bracket, if we were to use a 2125 wire in that 022 slot bracket, we'd probably be looking at about 5 degrees of play in either direction for a total of about 10 degrees of play, okay? But the truth of the matter is that hardly anyone uses that 2125 wire. So therefore, we're using a 1925 wire, and that gives us at least 20 degrees of play. Now, I think it's kind of comical when people talk about different torque values within prescriptions, because it doesn't really matter if it's 10 degrees or 12 degrees or 14 degrees of torque if you've got 20 degrees of play in the whole system. So I think it makes much more sense to use a wire and a bracket that fit each other intimately, where you have much less play. And I've got two just kind of quick demonstrations here. One is with an 022 slot system, there is roughly 10 degrees of play in either direction, and that equates to about 20 degrees of slop. Whereas in an 020 slot system, that same 1925 wire only has about 5 degrees of play in either system, in either direction. So therefore, in an 020 slot system, there's 2 times more torque control when you're using a 1925 wire than there is if you're trying to use that same wire in an 022 slot PSL bracket system. So what I love about the 020 by 026 system is the fact that very early on, you still get that really nice free-flowing, expansive rotational correction in a very low friction-free environment. And that happens while you're aligning the teeth and creating the teeth and getting them set up in your initial working phases. But then when the rubber meets the road and we get into our finishing stages, now we've got excellent control with this 020 by 026 system. So it really is kind of the best of both worlds. My grandfather used to have an old farm truck, and I used to love to go out and drive that truck. But one thing about that truck is that it had a lot of slack in the steering wheel. And what we know about an 022 bracket system is that we've got more than 2 times the slack in the steering wheel, and so this is really not the situation we want to have when we want to have control in finishing. So, and that's what this 1925 wire married with the 4 rigid walls of the 020 by 026 PSL slot yields excellent control in finishing. And that's where we're actually going to make up our appointments, our efficiencies, is in finishing. Yeah, I'm a little bit of a control freak when it comes to finishing. I like to finish cases with excellent control. I like to not have to guess as to where the tooth is going. whenever I put a bend in a wire or whenever I reposition a bracket. And I equate this amazing 3D control to going from, kind of driving that old farm truck in an old 2.2 system to driving a high-tech vehicle like a high-performance Tesla with an 020 by 026 bracket slot system. So with the Norris 2026 system, what you'll notice are a number of really cool key features. First of all, the brackets just don't come off. We have unparalleled bond strength to these brackets. And you'll know that the first time you try to reposition a bracket. You'll actually have to have the patient bite on a cotton roll. And there's some tips on our website, on our landing page, as to how to grab the bracket in order to debond it in a way that it does not distort the slot, because the bond strength is like no other. It really is almost like barnacles on a ship. And that interface, that bracket resin interface, is super strong. You'll find that we have these super strong, malleable, integrated hooks. And so these are so great because you don't have to worry about drop-in hooks or losing hooks or bending hooks or breaking hooks. The hooks on this bracket system are really pretty amazing. And I think you're going to love it. The door mechanism is fantastic. It actually has an auto open and auto close feature, so that as soon as you get the door more than 50% past its direction of travel, then it's going to continue either opening or closing on its own. And this is a big advantage. For instance, if you go and open doors and you want to remove the wire, well, they're not going to just magically or automatically close on their own. There's actually an internal spring clip which holds the door open. And so assistants will really appreciate that. It's got really great undertie wings, so you can put on Kobe hooks, you can put on elastic ties, you can put on colors, lig ties, whatever you need. We've got plenty of room with these superior tie wing undercuts to do whatever you need to do. And finally, this rounded leading edge of the door is really cool. It works almost like the tip of a ski, especially when you pair that with the rounded rectangular wires that are present in the Norris 2026 system. So the combination of these two really help to seat the wire in a buttery smooth fashion. And speaking of smooth, we've rounded the corners to make the bracket very soft and comfortable for the patient. Furthermore, this chrome cobalt material not only has superior sliding mechanisms, not only has superior sliding mechanics and properties, but it's also nickel-free. So you'll find that virtually all of your patients can tolerate this bracket in their mouth. There's very, very few patients. In fact, I haven't found any patients yet. Even patients that have other metal allergies are not allergic to this bracket because it is nickel-free. So all in all, we're now driving a very high-tech sports car with amazing control and really gets you to the finish line faster. So with this, I'd like to take just a couple of minutes to go through a really cool video that Dynaflex has done, just kind of pointing out some of the really neat features of this bracket system. I'm going to go ahead and narrate this as we're going through it. So traditional self-ligating brackets, they've lacked tip control and torque control. And that's one of the neat features about this 2026 channel is that we have superior control. We've already mentioned that. The bracket is chrome cobalt, and therefore it's nickel-free. The slot has superior sliding properties because of that chrome cobalt material. The premolar hooks are universal, and so you can use them first or second premolar. The center scribe line helps with placing the brackets on the teeth, and the mesial span of the door helps with rotational control. The straight occlusal edge helps with lining up as a visual cue to your marginal ridges of your premolars. And there's your deep under tie wing cuts that we talked about. Of course, the 2026 slot system is a major feature there. And of course, we just already discussed the unparalleled bond strength of this bracket system. This gingival curve actually follows the curve of the premolar teeth. And then the rounded leading edge of the door helps to seat the wire. And then we mentioned the flawless door opening and closing mechanism. So our extra broad arch wires provide a lot of buccal engagement and buccal development as we move through our normal sequence, which is 0 and 4, 1818, and 1925. With the 1925 in that 020 by 026 slot system, you get complete three-dimensional control. And there's really nothing lost by that rounded rectangular wire. So as you can see, these extra broad wires help to develop the arch laterally, eliminate the buccal corridors, and develop smiles that I think we can all be proud of. So thanks for letting me take a minute to just kind of go through that video with you. Let's see if we can pass forward here. All right, so as we launch into this talk, let's define efficiency. And in my mind, efficiency is the least number of appointments in order to achieve clinical excellence. And I have to confess, as a 23-year user of passive self-ligation, I thought I was pretty good. However, we actually did a study within our office where we compared 1,000 cases, 500 that were finished in 022 slot and 500 that were finished in an 020 slot. And overall, what we found was that it took 19 appointments on average to treat patients to an excellent finish in an 022 slot. Now, I have a heavily adult practice with a lot of interdisciplinary treatment. And so perhaps this is higher than you might expect. Well, this is actually the national average. So I thought I was better than average, but honestly, I was just average in an 022 slot. However, when we switched to an 020 slot 3.5 years ago, we looked at those 500 cases that we finished, and what we found was a 26% reduction in the number of appointments. We saved, on average, 5 appointments per patient. And the only thing that we changed was the bracket slot. So the wire systems were the same, the wire progression was the same, the wire shape was the same practitioner, the same office, nothing changed. And so really the only thing that can explain it is the fact that we had more control in finishing. And when we go back and analyze that data, that is indeed where the appointments were saved, is during those finishing stages of treatment. Does anybody know who this is? Well, it's one of the world's most famous investors, and his name is Warren Buffett. And if you look at Warren Buffett's investing history, he has produced a 22% return on investment. Pretty impressive in the stock market. But in orthodontics, well, maybe it's not quite so impressive, because with the Norris system, we were able to achieve a 26% return on investment. And I'll put my money on that any day. So with that, I'd like to launch into a few cases, the first of which is Sharon. And Sharon presents with an anterior open bite tendency, a very mild class 3 skeletal pattern as we look at her on the WITS analysis. Really nothing too big and crazy on the pano, except for the fact that her right mandibular condyle is slightly larger than her left mandibular condyle, which makes sense, as she has a little bit of a class 3 tendency there. When we look at her dental arches, what we notice is that her lower dental arch is fairly well developed. In fact, it looks a lot like the shape of the tongue, whereas her upper dental arch is not nearly as developed. So that tells us a story. It tells us that the tongue is probably resting not in the roof of the mouth, but it's resting in the floor of the mouth. Well, when Sharon first came in, I simply wasn't asking these questions, but the questions I should have been asking are, why is this? Why is the tongue not resting in the roof of the mouth? Is that due to a habit? It could be a constricted airway, and so maybe she's projecting her tongue forward, and because she has a reduced pharyngeal airway. Or could it be that she's tongue-tied and she simply can't get the tongue up to the roof of the mouth? All of those are possibilities. But the next thing I want to talk about is the definition of the smile arc. And we're going to define this as the curvature of the maxillary premolars, cuspids, and incisors in relationship to the curvature of the lower lip on a dynamic smile. Now, David Sarver is most famous for discussing smile arc, and I have to give him credit for sharing these slides with me. And he actually talks about the classification of the smile arc being either consonant, which is what we want, flat, reverse, or excessive. But he'll freely admit that he's not the first person to discuss smile arc. It was actually first discussed in a denture book by Frush and Fisher back in 1958. And then it's been discussed in several other articles since then, one by Halsey et al. In 1970, and by the Ackerman team a little later. So here's some of the factors that affect a smile arc: head position, variable lip animation, dentoskeletal pattern, tooth shape and attrition, tooth size discrepancies, incisor proclination, and then broad and arch forms. Methods to improve the smile arc include individualized bracket placement, which is what we're going to mostly talk about today, occlusal plane control, growth modification, orthognathic occlusal plane rotation, IPR and cosmetic incisor shaping, and then uprighting flared maxillary incisors, and of course cosmetic dentistry can change it as well. So let's look at Sharon. And let's look at her smile arc. Is it consonant? No, not really. In fact, I think it's kind of flat, or even a little bit reversed there in the interior. And that goes hand in hand with a class 3 skeletal pattern. Many of our patients who are class 3 will have a reverse smile arc. So she has a class 3 skeletal pattern with an anterior crossbite tendency. She has some mandibular asymmetry. She has a constricted maxillary arch, a large and powerful tongue with an anterolateral habit. She has low tongue posture and a reverse smile arc. Of course, she's got maxillary crowding and mandibular spacing. So we can't really talk about bracket position without first giving credit to Larry Andrews. And his F8 point is the midpoint on the facial axis of the crown, the most prominent point of the central lobe of each crown's facial surface. And Larry Andrews' point, F8 point, was the place where he felt the bracket slot and the wire should go. And I think that was a major contribution to orthodontics and got us much closer to where we are today in terms of concept of smile arc protection and smile arc creation. And so I have to give Larry Andrews a lot of credit for his research and his publications in getting us further down the road towards this direction. But as we all know, a lot of publications have talked about even increasing the amount of smile arc. And in order to do that, increasing the projection, increasing the amount of incisor display in our smile arc, so that we're actually bonding these brackets slightly apical to the F8 point that Andrews had previously described. And Dr. Tom Pitts and Tomas Castellanos actually developed a little chart here called the TomTom chart, which used the length of the canine as a guide to help in bracket position. And I think this is a major contribution. I have a little bit of a different take on this. I would much prefer to use the length of the central because I think it's more predictable. And sometimes we're actually using the height of the maxillary second premolar or mandibular second premolar, because very often that is a tooth that is not fully erupted. And so therefore that's our rate limiting step. That's our least common denominator, if you will, in determining the heights of the other teeth. It's the heights relative to the second premolar very often. And so this is the chart that we've come up with in the Norris 2026 system, and it's available on the website. And it's basically a chart for determining the height position for developing a really nice smile arc, a consonant smile arc. And there's the website where it's available, dynaflex.com/Norris 2026. Okay, so no matter who you're talking about, I mean, we all want the same thing, right? We all want to bond brackets with these three things in mind: gradient, projection, and a consonant smile arc, right? We might have different ideas on exactly how to put the brackets on in order to get there, but we all want the same thing, right? We want this radiant smile. We want a smile that projects into the room. We want a gradient display of tooth structure within the smile. So let's look at the bonding, the initial bonding that we did on Sharon. So what we have actually is almost, we've got the occlusal plane there, and we have this posterior occlusal plane, and these teeth are in occlusion there, but then we've got this sort of anterior occlusal plane, which definitely shifts in Kieran's particular case, okay? So we want to bond them, gradient, projection, and consonant smile arc. That's what we want. So we want to take that posterior occlusal plane, which is pretty good, and then we want to bond the brackets in such a way that we follow that reverse smile arc, so that when the wire is straight, we'll have a consonant smile arc. Okay, so we're basically incorporating this reverse smile arc into the bracket positions in order to achieve a consonant smile arc. So here we are, 2 months into treatment, and guess what? The PDLs have been loosened, and now that large, powerful tongue can actually push the teeth more. And so Dwight Damon used to call this waking up the tongue, but quite frankly, I don't think the tongue was ever asleep. I think the tongue was always pressing there, but the teeth had sort of found a happy medium between the lips and the tongue. And but now that we've kind of loosened up the PDLs, the teeth have started to drift forward, and that anterior open bite tendency is now becoming a frank anterior open bite. And of course, we are needing to put on some mandibular bite turbos in order to recapture the anterior crossbite that has occurred due to the mandibular teeth moving forward. Okay, so this is the kind of thing where you look at that when the patient comes back and you're like, uh-oh. There's a kind of look on your face. So, all right, so I mean, let's learn from this. How could this have been avoided? Well, one of the things we could have done, we know that she had that low tongue posture from the beginning. Perhaps we could have started with some lingual spurs to encourage her to have a more superior tongue position. That would have been one option. Another option would be to have her work with a myofunctional therapist to retrain this tongue to sit up into the roof of the mouth, and that's where we want it to be. Whenever we have nasal breathing, we want the tongue to support the maxilla and help develop the maxilla, and kids and adults, that's where we want. And we could have looked very closer at her narrow airway and perhaps looked at things such as tonsillectomy or a tongue reduction or maybe a lingual frenectomy to help reposition that tongue more anteriorly or take up less room in the floor of the mouth there. All right, so here we are 3 months into treatment with Ms. Sharon, and we have a 19 by 25 wire that we're placing in today. And so therefore we can put on an elastic chain, and we like to run these under the wire because we feel like it works more efficiently with less friction. And so that's what we did with Ms. Sharon. She still has those bite turbos, and we're still trying to recapture that bite. 5 months into treatment, you can see that we're starting to win here. We're starting to close up some of those spaces. And in fact, this is where we might put a chain under the wire and over the wire. And we're 5 months into treatment, and we're starting to get the upper hand on this anterior open bite. I'll back it up, of course, with some vertical elastics here on the sides. And so now we're 9 months into treatment, and as you can tell, we're definitely winning this battle. We've got 2 chains on the lower, one below, one above the wire. And so we just need to finish closing the rest of this little stubborn space and getting the teeth socked into their nice final occlusion here. Of course, backing it up with some vertical elastics. So here we are 9 months into treatment. Like I said, these are the previous pictures, but what do you notice about our wires? Well, if we do a really nice job with our bracket position, what that means is there's very few wire bends that we have to make. And so we can actually often finish our patients in either a 1925 NiTi wire or a 1925 beta titanium wire. And so that's kind of our goal, is to finish in one of those 2 wires and not have to go to a heavy, like a stainless steel wire. So here she is on her 8th appointment, 12 months into treatment. And I think we've established the fact that we've got a nice occlusal result, a nice aesthetic result, and we've done so in an efficient manner. And that is, like I said, our definition of efficiency. So is Sharon happy about it? Yeah, I think she really is. And I'm happy about it too. So how is it that we're able to get this result in such few appointments? And the answer is due to this control in finishing, which we've really never had. We just have never had this amount of control in finishing. So more torque control, more tip control, more rotation control, and control really without any compromise. So we get to use the wires that we like to use. We get to finish in the 1925 wires, and we just get great control in finishing. We already demonstrated we have twice the torque control, and so that's just really, really nice. We definitely have more tip control as well, and then of course more rotational control. Part of that is just simply the bracket depth, as well as the fact that the bracket door spans almost the entire width of the bracket itself. So let's talk a little bit about arch forms, because I've often been accused of having arch forms that are way too broad. But let's think about this as we look at our extra broad arch form, the Norris extra broad arch form, versus some of the other arch forms that are on the market. I mean, you might look at this extra broad arch form and you might think like, whoa, there is no way I'm going to put that in my patient. I don't want my patient's arches to look that way. And I see your point, but here's the deal. It's not that we want every patient to have this, Cro-Magnon arch form. We just simply want to go in that general direction. We want to expand arches and use very light, gentle forces to move teeth in that direction. How many of you use these reverse curve of speed wires in your patients? I often do. And why do I use them? Well, it's not that I want my wire to look like a reverse curve of speed like this. I just simply want the teeth to go in that general direction. I want them to go in the direction of basically, unwinding that steep or deep curve of speed that they currently have. So I put it in the opposite direction. Well, similarly, if you have a patient who have a narrow arch, you put in a broader arch. You basically build in some overcorrection, and that is going to help, give you an arch that's going to go in that general direction. Okay. Anna here, I think she's got a beautiful smile, and she was treated with a Norris 2026 wire system. And so just a real quick little video here about the wire system. So with that extra broad wire system, like I said, we do want to fill the buccal corridors, and we want to fill the slot eventually. So we start with this 0-4 wire. We move on to an 18-18 wire, and then a 1925. That's the largest wire that we use. That's our third wire. Then we take advantage of those rounded corners and the rounded edge of the door to fully seat our wire. And then sometimes we'll go forward with a beta titanium wire to help finish up if we're doing some little minor finishing bits. But with this wire, softly, gently, just a few grams of force in the transverse direction, we're able to develop some beautiful arch forms and some beautiful smiles. Okay, so we definitely want to fill those buccal corridors and have a gorgeous smile. I want to try to avoid dark buccal corridors here, and so that's kind of what we're after. Just a quick video here. We just in our nickel titanium wires, I actually took a little force gauge and put it on the wire so that we can determine how much force is being placed in the transverse dimension. And as you will see here in just a second, the amount of force is really minimal. In fact, I couldn't even get it to register on my force gauge. It's somewhere around 5 grams. It's just a really, really light amount of force. Versus with the beta titanium, 1925 beta titanium extra broad arch form, the amount of force that is exerted is only about 10 grams of force, as you can see here in this video. So it's less than 10 grams for the nickel titanium, and it's roughly 10 grams for the beta titanium. So I ask you, are Sharon's arches too broad? I don't think so. And you know what? Neither does she. But there again, neither does Brandon. He doesn't think his arches are too broad, nor does Anna, nor does Jamal, nor does Lola, or Fabrizio, or Rebecca. All of these patients were treated with the Norris 2026 extra broad wires. And so we're able to develop these beautiful broad arches that fill the buccal corridors and prevent those black triangles. And of course, you've got to have the maxillary bone there to help, to support that. I'm not one of these believes that you never do maxillary expansion. Sometimes we have to do the maxillary expansion because you've got to have the bone available. But with light, gentle forces, we can create smiles like Rebecca's. So let's talk a little bit about, well, let's look at another case here. Let's look at Sterling. And Sterling has a deep bite, and Sterling has some small lateral incisors. So let's look at Sterling's situation here. He's slightly class 2. Really nothing significant here on the pano other than the fact that he does have his wisdom teeth, which he's eventually going to need to have removed. So, but a fairly class 1 deep bite. We get Sterling strapped up with this Norris extra broad 0-4 bonded for gradient, projection, and a consonant smile arc. Trouble is, what's missing here? In a deep bite, we should actually have some anterior bite turbos on. And unfortunately, it just didn't happen that day. This is should be part of a system that was within my office, and our systems failed us that day. And so, there's several different places you can put these bite turbos. We would like them to be anterior either on the mesial of the upper premolars, like Keith Sellers recommends. We can put them on our cuspids. We can put them on our centrals or laterals, or a combination of any one of these. What we don't want to do is put them on our posterior teeth. Why is that? Well, many of these patients are low angle patients, and putting molar bite turbos on low angle patients are simply going to intrude those molars and make the deep bite worse over time. So therefore, we really prefer to use anterior bite turbos. So here's Mr. Sterling, 2 months into treatment, and we do have some bite bumpers on his lower incisors, which, you know, in a pinch, that's not a bad second place finish for in terms of opening up the deep bite. Backing it up with some vertical elastics here, and you know, we just didn't get that done. So here we are, 8 months into treatment. We're in a 1925 Norris extra broad wire, and just kind of socking things in with some vertical elastics here to help extrude those premolars, help intrude the lower incisors, and then have him wear some little class 2 elastics on the left side. We're 10 months into treatment, and what do you notice about his wires? Well, when the wires are placed, when the brackets are placed well, there's very little need for wire bending. I would much rather reposition a bracket than I would bend a wire, honestly. And so here Sterling finished up in 7 appointments, 12 months into treatment. And I think that his case demonstrates those qualities of efficiency, which is to achieve clinical excellence in the fewest number of appointments. And I think 7 appointments, I think we'd all be proud to treat cases like that and have this sort of arch development in 12 months of treatment. And more room for his tongue, more room for his airway. This is airway-friendly orthodontics at its finest. Is it too broad? I really don't think so. So let's look at Miss Carissa. And let's look very carefully at Carissa. She is skeletal class 1. Really nothing to be too concerned about here on her pano. She's a class 1 deep bite gummy smile type of patient. And when we're looking at how we're going to place her brackets, just look carefully here, because you know, if we want basically our wire to go, you know, right here in the middle through close to FA point, right? Well, what do we like? We like that tooth right there. We like that position. We like that tooth position, but we would like to intrude those 2 maxillary teeth, and we want to extrude that lateral a bit. And of course, we like the canine and the premolars on the right side. So how are we going to place our brackets? Well, we'd like to place our brackets in a way that we are going to intrude those 2 centrals and extrude that lateral to get us the consonant smile arc that we want. So that's how we place her brackets. We place them, you know, with gradient, projection, and a consonant smile arc in mind. We start off in an 014, and you know, very soon we're moving into our 1925 wire, 3.5 months into treatment. We're closing up some space, and you know, what do you notice about her wire here? You notice that it really doesn't have that many bends in it. And because we took our time with our bracket placement, and so when we were able to do this, we're able to treat our patients very efficiently. And yes, she does have a gummy smile. We're going to get into that a little bit later and talk about some of the reasons for a gummy smile. But right now, we're just kind of looking at the efficiency of her treatment time with 6.5 months in treatment, 5 appointments. And I think that very well qualifies for treating someone efficiently to an excellent finish. Let's look at Caleb. And Caleb is a kind of class 2 deep bite patient. And I'm going to encourage you to include these extra photographs in your photographic repertoire when you're taking your orthodontic records. The reason is that it allows us to document the fact that Caleb has a significant amount of wear on these incisors. And that is just not easy to document if you're only taking a closed mouth, you know, closing bite photograph. And so this is a nice medical legal document that is going to help protect you one day. Well, Caleb has a very mild class 2 skeletal pattern, deep bite, mild crowding, and worn incisal edges. He does have small lateral incisors, which contributes to his Bolton tooth size discrepancy. So let's talk about that. What are 6 keys to managing Bolton discrepancies? Let's talk about what are the reasons behind Bolton tooth size discrepancy. Well, of course, the most common one would be narrow maxillary incisors. And as we know, the maxillary incisor is one of the most commonly missing teeth, but it's also one of the most commonly misshapen teeth. Seems like they are very often narrow in shape. Another reason could be that you have wide mandibular incisors. You could also have excessive lingual crown torque of the maxillary incisors, excessive facial crown torque of the mandibular incisors, in other words, flared mandibular incisors. Or you could have a deep bite that contributes to a Bolton discrepancy, as well as thick marginal ridges of maxillary incisors. So those are the 6 things. And so what are we going to do about those 6 things? Well, if you have small maxillary incisors, well, obviously you could make space for restorations. But if you're going to do this, I would recommend that you intrude those lateral incisors. That way we have optimal gingival architecture and an improved emergence profile. And so we don't want to just restore them to look like short, fat chiclets. We want them to be have the appropriate length to width ratio of a beautiful tooth. We could also leave spaces mesial and distal to the lateral incisors for those patients who just don't want to have those restorations. And then the third option would be to sacrifice the bite slightly and leave the bite on a slightly class 2. And that's not my favorite option, but some parents have requested that, and we've done it. So large mandibular incisors, what can we do about that? Well, we can do interproximal reduction or stripping, right? And in a severe case, we could even do a mandibular incisor extraction. All right. Not my favorite treatment option because it often leads to excess overjet and excess deep bite, which I rarely like to leave my patients like that. And so you'll rarely see a mandibular incisor extraction case in my practice. How about excessive lingual crown torque of the maxillary incisors? Well, you could use high torque brackets. You could use an ART spring, an anterior root torquing spring. You could use a pre-torqued wire, but if you're going to do that, you want to make sure that your cuspid torque is protected, because the torque between the cuspid and the lateral will often sacrifice your cuspid torque. We use an anterior leash where we use an elastic chain. We place that leash gingival to the maxillary anterior teeth to help place a force which is gingival or apical and increases our inclination, increases our torque in the teeth. How about excessive facial crown torque of the lower incisors? Well, I mean, you can do the same thing there. You could use low torque brackets. You could use an ART spring pressing to the incisal, or you can use an anterior leash also pressing towards the incisal. What about deep bite? Well, we have lots of different ways to correct deep bites, including bite turbos. We also have bite plates. We could do reverse curve wires. We could do step down wires. We could combine all of this with SFOT, surgically facilitated orthodontic treatment. Or we could even do surgical correction for a skeletal deep bite. So all of those things could help us correct deep bites. How about thick marginal ridges on maxillary incisors? Well, there's really only one treatment for that, and that is to get in there and do some enameloplasty in those thick marginal ridges and to make them, normal in their size and shape. So those are the 6 things, the 6 solutions, how we can resolve Bolton tooth size discrepancies. So let's get back to Caleb and look at how we bonded him. Okay, so we bonded him. This is the day of bonding, an 014 NiTi, using the principles of gradient projection and constant smile arc. But what's missing? Once again, our anterior bite turbos are missing in a deep bite patient. And which bracket position could have been improved? Well, it's actually the lateral incisor. Even though I moved it a little bit towards the incisal, I should have moved it even further towards the incisal. And I'll show you why here a little bit later. So we're 2 months into treatment. We're in an 1818 wire, and these are all Norris extra broad wires. Of course, we're using some light early elastics in order to help our class 2 correction. We're 6 months into treatment now, and we have done some restorations on those lateral incisors to make them slightly larger. So our error here is that we did not fully correct the class 2 relationship first. In other words, we didn't get to class 1 canine before we restored those lateral incisors. We should have gotten to class 1 canine first and then restored the lateral incisors through a process called dynamic bonding. But we didn't do that. We just simply guessed at how big those lateral incisors should have been. And so it ended up that those lateral incisors were not quite big enough. And we were left ultimately, when the case finished, I'll let you see, but we were left with a slightly class 2 malocclusion on the left side because the laterals were not quite large enough to accommodate for the tooth size discrepancy. So once again, if we use judicious and careful and accurate bracket positioning, we can get by with wires that have very few bends in them in finishing. And so here we are, 10 appointments, 10 months, and I think we have a result that we're pretty proud of. However, we do have a very slight class 2 ishness to the patient's left side, and that could have been avoided had we waited until we got into class 1 before we'd done those incisors, and had we moved those brackets slightly incisal to improve the gingival architecture, and especially on that left lateral incisor, made that left lateral incisor even larger. Okay, so let's look at Alana. And Alana obviously has some crowding going on. She's got a narrow maxillary arch, and she does have some wear. So once again, these pictures come in handy whenever we are documenting a case like Alana's. And in Alana's situation here, we've got a very mild class 2 skeletal pattern. She actually has no mandibular third molars, but she does have maxillary third molars. She's got a class 2 deep bite, narrow maxillary arch, bilateral posterior cross bite, and worn incisors. Okay, so when we are placing Anna's brackets, we want to do so with the concept of, guess what? Smile arc, consonant smile arc, projection, and a gradient. So what's missing, once again, is the bite turbos, and which bracket positions are incorrect. Well, I actually, I don't like the axial inclinations of the maxillary centrals, and so we went back and repositioned those brackets. And so as you can see, early in treatment here, as we went from the crowded situation to the day when we inserted her 1818 wire, we got really fast movement and alignment of these crooked premolars. And so this is just the day we put the 1818 in, and we made a lot of progress there just with that one wire. So you get really fast early alignment with very low friction, and yet towards the end, when we're starting to engage torque and actually engage the wire in all 3 dimensions, you get the active control. It's actually so you have a passive bracket in the beginning, and you have an active bracket to finish. And that really is the best of both worlds. Just simply with the 014 NiTi, we get a lot of that resolution of that crowding there. So continuing in her treatment, and I must say that Alana was not the best patient in terms of showing up for appointments, brushing her teeth, or wearing her elastics. So we asked her to continue wearing those elastics, especially on that left side, and some crossbite elastics. Of course, we could have done a little better with that bracket position there on the lower left second premolar. And eventually we're going to need to make some little steps there to upright those and make those marginal ridges even between her first and second molars. But the beauty of it is with a passive self-lighting system on the 6th, it makes making those step bends quite easy. You can step a molar up or down or in or out, whatever you need to do, because you can still get the wire back through the PSL door on the 6th. And so very often we will bend NiTi, and I just created this little video here on how to bend nickel titanium. In this particular video, we are bending some little step down bends to help open up a deep bite. And so you just simply grab the wire with your favorite wire bending plier. I like a thin beaked Weingart plier because that kind of gives me a sharp edge around which I can bend the nickel titanium wire. And if you remember, nickel titanium or NiTi, it exists in 2 phases, the martensite phase and the austenite phase. And so there's 2 different ways that you can change those phases. One is through temperature, and the other is through mechanical work hardening or basically crushing the grain structure to go from hexagonal close pack to body-centered cubic. And we can actually change the structure of the wire and put some bends into a nickel titanium wire if we'd like to. And those will hold. So back to Alana, and she's using a class 2 elastics plus some cross-bite elastics. And once again, we notice there's very few bends in her wires as we approach her finishing stages of her treatment. And then once we're all done, I think we've got a result which is, 19 months in treatment, but I can't help the fact that she simply didn't show up for several appointments. However, 11 months total treatment time, which I think is a fairly efficient way to treat a class 2 patient with a bilateral crossbite. So look at the amount of arch development we got on Alana, and I think it's pretty impressive. And it allowed us to correct the posterior crossbite, in this case, only with some crossbite elastic in the extra broad arch form. All right. So the last case before we jump into the interdisciplinary cases, and this is Miss K. And K has, well, as you can see, class 3 tendency with an anterior crossbite and a lot of crowding. So let's look at Kay a little more closely here. And of course, her widths analysis is showing class 3 skeletal tendency. Her pano is pretty unremarkable. And when we bond Kay's brackets, we're going to consider, we know that those maxillary teeth are going to come forward, and especially on that blocked out lateral incisor. So what we'd like to do is go ahead and spin those brackets around and flip them, okay? And so that when we put our wires in and put our coil springs in, things are going to start to come forward, and we're going to engage that lateral incisor. And in this particular case, we actually did flip that lateral incisor, but actually I wish I had flipped all of those incisors to improve the angulation of her maxillary incisors. So we're 13 months into treatment, and we have Miss K working on some finishing elastics here. We're 15 months into treatment, and we're just kind of trying to dial in her occlusion. And here she is 17 months into treatment. And we've got a result, but 10 appointments. I think we can be pretty happy with the efficiency that we achieved here on K. And I think we've got some really nice arch development, and some huge improvement in our occlusion. And look at the difference in her dental arches there between start and finish. And really, in this particular case, nothing but the extra broad wires and some light elastics to develop those arches. So let's talk a little bit about interdisciplinary treatment. And we're going to go through 3 cases here. And we can't really talk about interdisciplinary treatment without talking about my dear friend, Dr. Bill Robbins. And I'm so fortunate in that I live in San Antonio and I get to work with Bill on a daily basis. He's the author of a textbook that we should all have in our library, and that is Global Diagnosis, or the core system of diagnosing interdisciplinary patients. Not only am I fortunate to get to work with Bill Robbins, I also am fortunate to get to lecture and teach with him. He's a dear friend and has been a mentor of mine for many years. And so let's briefly review the 5 core values that he delineates in his book. And they are facial height, lip length and mobility, gingival line or gingival architecture, tooth length, and he's talking specifically about the maxillary central incisor, and then whether or not one can feel the CEJ within the sulcus. And this is a determination of whether or not the patient has altered passive eruption. Okay, so those are all normal levels and normal things that we would like to see in our patients. If they're not, then this tells us and gives us a guide on how we can get these parameters to normal. And so let's talk about Miss Melissa. Let's apply Dr. Robbins' core principles of diagnosis to Melissa. So let's first start off with Melissa. She's a class 1. She's missing some third molars there. But let's look at her anterior facial height, and it's 58 millimeters versus 57 millimeters. Pretty darn level in my book. And so the next thing we look at is we look at her lip length, and her lip is measuring 20 millimeters, which is normal for a female, should be 20 to 22 millimeters in a female. The next thing that we're going to look at is the lip dynamics or lip mobility. How animated is her upper lip? And she went from really showing about 1 millimeter to showing about 3 millimeters. So her lip mobility was maybe 3 millimeters at best. And so I have to consider that this patient may have either a very guarded smile, in other words, she has trained herself not to smile because she is self-conscious about her teeth. Or it may be that she has used Botox in her upper lip, and so that has reduced her lip animation. When we look at her gingival line or her gingival architecture, it is indeed level. And when we measure the length of her maxillary central incisor, it measures out at 8 millimeters. And so that tells us that the tooth has experienced about 2 millimeters of wear, because we know that a maxillary central incisor is roughly 10 millimeters tall. So let's look here. So on Melissa, she was a 1-to-1 facial height ratio. Her lip length was normal. However, her lip mobility was abnormally hypomobile. Her gingival line was indeed level. Her gingival architecture would look good. Her tooth length was 8 millimeters, which are short. And then we could feel the CEJ within the sulcus. So what are we going to do? Well, we start by making the teeth the appropriate length that they should be through pre-orthodontic bonding. And then we're going to bond the brackets on the teeth in a way that's going to give us projection gradient and a constant smile arc. We're also going to add some bite turbos and start her on some vertical elastics. And so here we are 4 months into treatment. She's in her 1818 wires, and she's wearing those seating elastics, early, short, light elastics to help seat the premolars into occlusion. And we're 6 months into treatment. We're in her final sized wires, 19 by 25 wires, and we're starting to dial in her bite. And so these provisionals that we had done for her, these composite provisionals, once we're done with her orthodontic treatment, we're going to allow her dentist to take those off and replace them with porcelain veneers when it's all said and done. So we're 7 months into treatment. Notice that we have very few wire bends there, except for a little step down bend between the lower incisors. So we're 8 months into treatment, 6 appointments, and I think we have a result that I'm pretty proud of. I think she looks amazing. And so now she is ready to go back and once these teeth settle, she can go back and get those porcelain veneers on those maxillary anterior teeth. Efficient? Well, I think so. Let's look at Mariola. And Mariola is 40 years old, and she grew up in a country where dental treatment was not a priority. And so she has a lot of dentistry that is questionable. And so when we look at her, we see a couple of things. First of all, we see an underdeveloped maxilla. She's a skeletally class 3. We see a lot of dental work, much of which is questionable. So the restorative dentist would like to remove a lot of these restorations and provisionalize her. Let's put her through the core diagnostic process. And when we look at her anterior facial height, we see that she is 58 millimeters on the upper facial height and 65 millimeters on the lower facial height. So she's got a long lower facial height. When we further analyze that lower facial height, we see that it should be 1/3 of the upper lip and 2/3 of the lower lip and chin. And her upper lip measures 18 millimeters, so therefore that lower lip and chin should measure 36 millimeters. However, instead it measures 43 millimeters. So what that tells us is that, number one, she's got a slightly short upper lip, and number two, she has a fairly tall mandible. Okay, so when we look at our upper lip length, her upper lip is measuring 18 millimeters, slightly short. Okay, and very often that short upper lip is an indicator of someone who's been breathing through their mouths all their lives, because mouth breathers will often have short upper lips. When we look at her lip mobility, it is 5 millimeters. Once again, normal lip mobility should be somewhere between 6 and 8 millimeters. And when we ask her, she actually has been using Botox in her upper lip. And so that is why she has limited lip mobility. Is her gingival line level? Well, no, it's not. So that's something that we're going to be working on here throughout her ortho restorative process, because it is not level. When we look at her length of her maxillary central incisor, it actually measures 10 millimeters. And so that's a good tooth length for us to start with as a guide. All right, so let's look at Mariola's results regarding the 5 core values. And her facial height is long. Her lip length is slightly short with a hypomobile upper lip. Her gingival line is not level, and her tooth length is normal. And we are able to feel the CEJ, so therefore she does not have altered passive eruption. Okay, so she has a skeletal class 3 tendency. She has a maxillary AP deficiency, a maxillary transverse deficiency, multiple missing teeth, a short upper lip, and she does have a history of nasal obstruction and mouth breathing. She has a hypomobile upper lip and a long mandibular height. So what are we going to do for Mariola? What's her ideal treatment plan? Well, first of all, we would like to remove all the old restorations and provisionalize her. That way, her restorative dentist does not have any surprises when he takes those things off at the end of orthodontics. And then we'd like to do orthodontic pre-surgical bonding. In other words, we place her brackets on her teeth and prepare her for orthodontic surgery, where we would ideally like to do a maxillary advancement and expansion, plus a vertical chin reduction. Then we would, of course, complete our orthodontic treatment, get her back to her restorative dentist for him to extract the upper right 6, tooth number 3, and then have implants in these areas for these missing teeth. However, Mariella says, well, all this is good except for the fact that I'm not going to do an orthodontic surgery. Well, that kind of throws a little bit of a curveball into the situation, because how are we going to correct that deficient maxilla without doing surgery? Well, and so that's what we're going to do, is to use the tools that we had at the time. And I treated her about 4 years ago, and this is what we had at that time, to use SFOT to maximize the maxillary alveolar expansion. Everything else remains the same, including completing her final restorations once we're finished with everything. So here she is after her provisionals are done. The dentist has taken off those old restorations and replaced them with provisionals. So now he knows what he's dealing with underneath there. Here she is the day she got her brackets on, and then we sent her to the periodontist to do the SFOT and add the buccal and facial bone, so that we could then start to do some arch development and alveolar expansion. Here she is 1 month into treatment. 4 months, or excuse me, appointment number 4, 3 months into treatment, and you can see that we added some lingual buttons here so that we could help upright the help expand the upper arch using some crossbite elastics there. So that's when we started the crossbite elastics, and she was a really good patient. She wore those elastics, and here we are 9 months into treatment, and we have a kind of a halfway decent result, right? So we've gotten some more arch development. We're kind of stretching and reaching and bending the alveolar process, and I had just gotten back from a course in maxillary skeletal expansion, an MSE course called MARPE. And so I approached Mariella and I said, hey, listen, how would you like to be my first MARPE case? And she said, well, she'd be willing to give it a try if she thought it would give her a better result, as long as it was a non-surgical approach. And so this is kind of the amount of maxillary development we were able to get within 9 months. And it's an improvement, definitely. However, we gave her MARPE and we started turning it. And eventually we were able to get a split, even though she is over 40 years old. We were able to get a non-surgical split, and we were able to expand her maxilla significantly. So let's get back to the cone beam CT, where we see on the left, you can see the MARPE screws, or the TADs, which are giving us bicortical anchorage here on the left, and the floor of the mouth and the roof of the mouth and the floor of the nose there. And then on the screen on your right, you can see that this is the new bone that's forming, or has formed. But not only that, look at the amount of airway improvement that we have gotten through that maxillary skeletal expansion. So we're at appointment number 10. We're 13 months into treatment, and this expansion has caused a bit of an open bite. So we put in a meow wire, and that's a multi-loop edgewise arch wire, in order to help close that open bite. And 1 month later, we have that open bite under control. And so at this point, I think we're taking out our MARPE, and we are just finishing up her treatment using some elastics. And we are 16 months in orthodontic treatment. And here she is, just in those provisionals. Of course, that upper right 6, tooth number 3, has been now extracted. Now she's just kind of waiting for our final restorations. And I don't have follow-up pictures on that to show you, but her dentist is very confident that he can give her an amazing smile at this point, once we get her maxillary implants placed. All right, so efficient I think so. 13 appointments for a really tough interdisciplinary case like that, where we had to sort of switch gears halfway down the road. I think that is efficient. What's interesting is that she reports, breathing so much better after she got her MARPE split. So here she is before and after, and look at the amount of arch development, not only in the upper, but even in the lower. I mean, that is an amazing amount of arch development. And I think it's a really cool thing. She's got so much room now for her tongue, and she freely admits that. She loves having all that room for her tongue, so she breathes so much better. So here she is, initial and final. And I think it's due to the control and finishing that we were able to complete that case in a fairly efficient manner. So last case here, and this is Marcy, and I'm going to give you two guesses as to what Marcy's chief complaint is. So, of course, Marcy's chief complaint is the fact that she has a gummy smile. And so, if we're going to treat gummy smiles, we need to have a better and a deeper understanding of gummy smiles. So we're going to talk about that here in just a little bit. So Marcy is fairly class 1 in her skeletally speaking. She does have, well, let's go ahead and dive into those 6 factors affecting the gummy smile. So you can have a short upper lip, and we talked about patients who often are mouth breathers will often have a short upper lip. Whereas a normal upper lip is somewhere between 20 to 22 millimeters in females, 22 to 24 in males. So often, if a patient does have a short upper lip, it's often the result of nasal obstruction and mouth breathing. Okay, so there actually is a treatment for that. There is a lip lengthening surgery that can be done to increase the length of the upper lip, and a plastic surgeon would be the one to do that. Okay, so the second factor there would be hypermobility of the upper lip. In other words, they've got an average size of incisal display, but their lip has too much travel in it, and so it's hypermobile. Normal amount of change between lip at rest and a lip on a full animated smile should be somewhere between 6 and 8 millimeters. Hyperactivity of the levator labii superioris muscles are what causes that, and what can treat it is Botox or Dysport, some other form of neurotoxin in that upper lip to decrease the mobility of that upper lip. Another thing that could cause a lot of gumminess in the smile would be altered passive eruption, and we mentioned this earlier, but the proper definition here is incomplete apical migration of the dentogingival complex during growth. And so this correction here is, we should be able to see and feel, not see, but feel the CEJ within the sulcus. And if not, then the patient has APE, and the correction for APE, ultrapassive eruption, is osseous crown lengthening, where we, well, not we, but where the periodontist would remove bone to a knife edge shape 3 millimeters from the CEJ, and then replace the flap. Okay. Gingival hyperplasia would be another possibility for a gummy smile. And of course, this can have can come from either medications, orthodontic treatment, or periodontal disease. The treatment for hyperplasia is simply a gingivectomy. Then we can have dental alveolar extrusion, which just means the teeth have over-erupted. And over-erupted teeth bring gingiva and bone with them. Okay, so the treatment here is orthodontic intrusion. Just move the teeth back to where they used to be. All right. And of course, the last thing that it could be a vertical maxillary excess, or VME. That can be one of the causes of a gummy smile. All right. Now, very often with this, you'll see a long lower facial height, and so therefore the treatment is maxillary impaction surgery. Okay, so those are the 6 things, and let's see how we do if we apply those things to Miss Marcy here. So her upper facial height was 58 millimeters. Her lower facial height was 63 millimeters. So we know that she has a long lower facial height. Her upper lip length is 20 millimeters, which is average. And her lip mobility is 7 millimeters, which is also average. Remember, it should be somewhere between 6 and 8 millimeters. So 7 millimeters is just about right. So that's fairly normal. Is the CEJ, or excuse me, is the gingival line or the gingival architecture, is it level? No, it's not. And is her upper tooth length normal shape? No, it's not. It's only 7 millimeters. So what we have is she's got a long lower facial height. She has a fairly normal shaped upper lip, in terms not only in terms of its structure, its morphology, and its animation. All of that is pretty normal. However, her gingival line is not level. Her teeth are short due to wear, and we cannot feel the CEJ in the sulcus. All these things fall outside the normal parameters. So she has a class 1 malocclusion with severe anterior wear, a gummy smile, altered passive eruption, vertical maxillary excess. So what's the treatment for her? Well, it's going to be periodontal crown lengthening, provisional restorations to lengthen the worn edges, orthodontic pre-surgical treatment, and maxillary impaction surgery. The only trouble is that she declines maxillary impaction surgery. She doesn't want surgery. So what are we going to do? Well, how can we impact the maxilla without orthodontic surgery? It's going to make a tough one. And, you know, this doesn't instill a lot of confidence in us, especially because she drives 8 hours each way to come see me. So we're going to go ahead and bond the orthodontic brackets. We're going to do some SFOT plus crown lengthening and install some skeletal mini plates so that we can have absolute anchorage as we are intruding her maxillary teeth. We're going to do some maxillary orthodontic intrusion, full arch intrusion, followed by provisional restorations to lengthen the worn edges. And the reason why we don't want to do these immediately in this particular case is that she would be too toothy. She would look kind of horsey if we did them on the front end with pre-orthodontic bonding. So in this case, we're going to do some dynamic bonding and do it halfway through treatment. So then we're going to finish our orthodontic treatment and then do her final restorations. All right. So we're going to get started on Marcy. Here's the day she got her braces on. We are going to start to, here's after her SFOT and after her plates are installed. And as you can see, we want those plates installed a fair distance away from our maxillary appliances because we're going to be intruding those teeth towards those plates. And on the lingual, we've got some mechanics to keep those molars and premolars from rolling facially. And also we have a little button so that her tongue can help us push those maxillary teeth apically. We're several months into treatment here. And so we've actually gone back and we've done some microosseous perforations or a MOPS procedure to help intrude those maxillary teeth even more. And then we're going to gain another RAP effect, a regional acceleratory phenomenon. We're then going to add a kind of a piggyback wire to help us intrude. So it's a pure intrusion wire off those skeletal mini plates. And that's going to help intrude those maxillary teeth, maxillary anterior teeth in particular. And then once we get those teeth up to a place where we like the gingival architecture, we'll temporarily take off our brackets, send her back over to her dentist, and then the dentist will lengthen them back to the sizes that they should be. And now we'll go ahead and bond our brackets back on, and then we'll continue getting through her treatment. And we are about 9 months into treatment at this point. We actually don't have a lot to go. We actually just kind of need to sock in her bite, which we can do with some elastics here. and take a look at the skeletal anchor in relationship to the wire here. Just 10 months into treatment, we have really intruded those maxillary teeth significantly. And so here she is after her braces are removed, and these are her provisionals. And of course, here she is after she has her final restoration. That's the day that they were delivered or inserted. But wow, what a change between not only the arch development and her occlusion, but the major change that she's most happy about is in her gummy smile. And of course, we addressed her chief complaint here. And I think the dentist, in this case, it was Dr. Bill Robbins. I think he just knocked it out of the park with an amazing result, and it allowed us to treat this patient very efficiently, especially since they were driving so far to come see us. All right, so with the Norris 2026 system, honestly, it all boils down to time, right? Less chair time, fewer appointments, time to work on your business instead of in it, and just uncompromising control and finishing. It's really, really an amazing system, and I'd be honored if you tried it out. With that, I hope that you have appreciated the birth of this 2026 active-passive concept. I hope that you have appreciated the value proposition of the Norris 2026 system. And I hope you've enjoyed the Class 1, Class 2, and Class 3 cases that can be treated efficiently using this system. And I also hope that you enjoyed perhaps some of the approaches we took when we applied the core diagnostic system to treating interdisciplinary cases. And with that, we're going to just take a short break here as we answer some of the questions in the chat box. And let's remind ourselves that efficiency is treating a patient to a state of clinical excellence with the least number of appointments possible. And so we're going to just take a quick break here while we answer and get organized and look at our chat box here. We'll be back in just a minute to answer some of those questions.
All right. Thank you. That was awesome. Hopefully everybody can hear us okay. Looking good as always. So we have a lot of people that logged in, and I'll just speak for all of us. That was really something else, and we appreciate the time, and we appreciate all the attendees' time as well. Some are all over the world, and I'd like to get to some of their questions in respect to their time as well. And we are going to start with a doctor right here in the States. Can you explain, Dr. Norris, in as much detail as possible, the power chain under the wire for the Norris system?
Sure. So, I mean, anytime that you put any kind of elastomeric, whether it's an O-ring or a power chain, and you're covering the wings of the bracket and you're covering the wire, you're actually creating friction between the wire and the bracket with that elastomeric. Back in the day, we used to call this bungee donics. And so by putting the power chain underneath the wire, that's allowing the full force of the power chain to pull the teeth together. I mean, imagine that you just didn't put any wire in there, right? I mean, then that would truly be a friction-free system where the teeth would just be pulled, totally lingually. And essentially, that's what we're doing. And we just kind of have the wire to guide the teeth, into that arch form, if you will. And so we're kind of just eliminating that binding and that friction that happens when you put an O-ring or a chain over the wire. That's what it's all about. Gotcha.
Give some tips for premolars, right? You have, there's a doctor asking,
placing brackets on shorter crowned premolars in particular?
Yeah. Well, I mean, that's a tough one, and that's actually the exact reason why we changed the bracket and with this Norris 2026 system, when we gingivally offset the bracket as much as we possibly could, so that so that with those short premolar crowns, we still have adequate bond strength. And if you look at the surface of a premolar, okay. And let's call this the occlusal, and let's call this the gingival, right? A couple of things happen. All right, so first of all, as you move more towards the occlusal, the enamel gets more regular and it actually gets stronger up there. As we move towards the gingival, the enamel gets more amorphous, and so you don't have as good a quality of enamel as you get towards the gingival surface. And you also have to deal with the gingival curvicular fluid that tends to be weeping out of gum tissues, and if you're bonding close to short teeth. So even if you don't get a great bond strength down here, you still have this occlusal pad, because the bracket is down here near the gingiva, and you still have this occlusal pad that's getting this great bond strength up here with this really good high quality enamel. And so even on relatively short teeth, you can actually push it into the gingiva, and sometimes you can branch the gingiva if you have to, and you can still get a really nice bond strength because we're bonding to the best enamel on the tooth, which is kind of the middle to upper third of the tooth. So it works better than any other bracket system I've used, because the bracket is so gingivally offset on that pad, and you've got the really nice flat cue to use to basically line up your mesial and distal marginal ridges with that occlusal edge of the bracket pad. And gosh, it's so easy to get that bracket on just right with this new pad.
Yep. Yeah, we actually have a video of that description on the Facebook page. So I happen to know this doctor asking the question, and I'll make sure that we give them a link to that. This next question too, we have a video in regards to debonding the bracket for repositioning versus debonding it for final debond. I think what they're saying is they've had a couple brackets where the slot might have distorted a little bit.
Right, sure.
And what are the tips there?
Yep. So like Mike mentioned, what I'm going to do is I'm going to actually send you to the Dynaflex webpage, Norris 2026 webpage, where we actually have a video of this. But there's two ways to grab the bracket. Typically, if we're going to debond a bracket to remove it from the tooth, and the braces are off, and we don't need those brackets anymore, we're going to grab that bracket basically incisogingivally, right? And we're actually going to intentionally squeeze those wings and distort the bracket, because that distortion actually bends the pad and it peels the bracket off the tooth, and the patient's going to feel less discomfort when you do that. So it's the most comfortable way to remove a bracket. And if you want to take that a step further, actually go ahead and just remove the arch wire, and that's going to allow even more distortion of those wings, even more peeling of that bracket off of the tooth. However, if you want to reuse that bracket and reposition that bracket, well, rather than grabbing that bracket occlusogingivally, what you do is you actually grab it at a 45-degree angle, so that we are grabbing basically the here, let me have a model here. Okay, so that essentially we are grabbing it from this wing and this wing, or from this wing and this wing, right? And you're grabbing it like this, but you're not squeezing, okay? All you want to really do is hold it in place, and then with a real quick little flip of the wrist, you want to just pop it off, okay? Mm-hmm. So hold it on this wing and the opposite wing here, just like that, with your debonding plier, and then just and stabilize the tooth, have the patient bite on a cotton roll, and then boom, pop it off. Just boom, just real quick, like roll the wrist, but roll it fast, okay? Yep. It'll just pop right off. Okay, and there's a video of that, like I said, on the website.
Yeah, the video is really helpful. Okay, so this is a great question. Does the Norris system have variable torque prescriptions? in the presentation, it showed a case where the brackets were inverted to upper 2 to 2 for class 3 case. Do you invert brackets often when you need less torque?
Yes, we do. So I haven't felt the need for a variable torque system. Essentially, all we've got to do is just kind of identify the case, hopefully, early on, and that way you can, because you're going to start to pick up torque in the second wire. When you've got an 1818 wire in there, you're going to start to enjoy very, very early, torque control. And so the best thing to do is get those brackets on, in the proper orientation, and particularly if you've got a severe crowding cases, a class 3 cases, a class 2 case where you get the, incisors flared and so forth, and just flip those brackets early on and start enjoying that early torque control. And that's honestly, I've been using this bracket for nearly 4 years now, and that's all we've really needed. We haven't really needed variable torque control. But okay, I'm going to give you a little tip since you asked about variable torque. Let's for instance say that you've got a maxillary premolar, which you've got a little too much, let's say, buccal crown torque on it, and you want to tuck it in just a little bit, or maybe it's a cuspid even, a little bit of max torque. What you can do is you can take a lower premolar bracket, but actually has more torque on it than an upper premolar bracket. Take a lower premolar bracket and just kind of cheat, and for instance take a lower premolar bracket and just move it to whatever tooth needs to be tucked in a little bit, and that'll actually help in those instances. So you can kind of play with the system once you understand the torque values. And the torque values are very clearly stated once again on that same website, Dynaflex/Norris 2026.
Yep. Okay. This is from a doctor. I use a 22 by 28 self-ligating system, and I finish with a 21 by 27 wire. Interesting. I've never seen that wire, but 21 by 27 wire. What is the difference than using a bracket with a smaller slot size?
Less force on the teeth. Your patients will have less root resorption. Your patients will have less pain. You'll have fewer bracket failures. I mean, whoever this is, you're the only person I've ever met in my entire 25-year career who is using that combination of 022 and 21 by 27 wire. So kudos to you for filling the slot, but I wouldn't want to be one of your patients.
All right. Okay. So I think this is possibly an international doctor, but they're very grateful. Thank you. Amazing presentation. And they wanted to ask about upcoming webinars and the course in office. Are we planning a next one?
There will be a course. Tentatively, we are hoping for the spring. Obviously, we're all kind of watching the, I don't know if you've heard that there's this pandemic thing going on, but yeah. So we're actually watching that very carefully, and we're hoping to see this thing going the opposite direction than what it's currently going. And so, we've actually conducted 2 in-house courses, sort of like dry runs, if you will, and we were able to do so in a very, very safe manner. My wife is a physician, and she has arranged for attendees to get tested, as soon as you arrive. Social distancing, all meals outside. We're following all the protocols, and so yes, it is going to happen. It's just a matter of time, and managing the COVID situation, and it's the attendees, and thus far we've had 15, 18 attendees or something like that. I mean, they've been very pleased with what they've received over those those days. It's not only a really great learning weekend, but you get a really nice taste of San Antonio. We get some amazing food that comes in. We do a sunset dinner cruise on the lake, but we get to dive deeper into the clinical stuff and show some tougher cases and really look at the finer points of bracket positioning. It's a cool deal.
Yeah, I mean, I've been able to appreciate it in person, and I've been through a lot of those courses in multiple offices, and it's value packed, and it is unique. It's something that a lot of doctors will appreciate experiencing. Okay, questions keep coming in, so we're going to try to get to as many as possible. This has to do with arch sizes. Do we have an upper and a lower arch wire, or just one size for all? And do you arch coordinate? Are you arch coordinating once you are in beta titanium? And do you use stainless steel wire?
So 3 questions in there. One for all. So same arch, and so therefore you don't have to arch coordinate because it's one arch for all. Second question is something about beta titanium. So beta titanium we don't arch coordinate because we got that. All right. Do we ever use stainless steel? I use stainless steel if we're going to have an extraction cases and we're trying to close spaces on extractions. It's very rarely do we extract in our practice, but we do. I use stainless steel if we're going to add like a forceps appliance. I'd like to be in stainless steel for that. And then I also use stainless steel if the patient's going to go to surgery, because I like to solder surgical lugs to those stainless steel wires. The surgeons like them. Those are kind of like the 3 cases where I'll use stainless steel. Otherwise, it's either NiTi or TMA to finish in my practice.
Yep. And we are developing the 1925 rounded rectangular stainless steel. Should be available shortly. And I think a number of doctors asked for it for extraction cases and the CS system that we talked about as well. Okay. That may be it. I don't want to miss any. I think that's it. And we have plenty of opportunities to continue this conversation. We're going to do more of these CE webinars. Actually, this is 1.5 credits. We initially had this as a 1 CE credit, but you will receive a email within a week, and it'll be an hour and a half worth of CE credits there. And I just want to say thank you. Thanks for everybody that spent their evening with us. Thank you to Dr. Tito Norris, that I think may want to say one more thing.
No, honestly, I really do want to I'm really grateful for everybody that showed up tonight. I know a lot of people just kind of webinared out and so forth, and it really means a lot to me that you guys stuck with the program here. It was kind of a long night, and I know everyone's tired at the end of the day, and I'm very grateful to everyone for their time, for their attention in listening to this program tonight. So thank you.
Yeah, awesome, guys. Thank you. We will follow up. There's going to be plenty of opportunity to reach out to us if you have additional questions that we didn't get to. And we look forward to seeing everybody soon in person, right? In person.
Yep.
All right. Take care, everybody. Thank you for joining us.
Good night.
Bye-bye.